Hi everyone, thanks for listening to my presentations. Today I'll be talking about hypothyroidism and I'll limit myself to causes, diagnosis and differential diagnosis of hypothyroidism. This will form part 3 of 7 when it comes to the series on hypothyroidism. Part 1 was on Hashimoto Thyroiditis, without which we cannot complete the story around hypothyroidism. And part 2 was on symptoms and signs of hypothyroidism. And I've taken time to explain in details that hypothyroidism could affect all organs and all systems. So if you haven't listened to them, please kindly go through the parts 1 and 2 on my channel. Okay, for today, let's go. Hypothyroidism could be caused upstairs, that is central problem, and that will involve hypothalamus and the pituitary. So if it is central hypothyroidism, the problem will be from hypothalamic to pituitary in nature. Okay, in that case, we're dealing with thyrotropin releasing hormone deficiency from the hypothalamus, and that will be leading to thyroid-stimulating hormone deficiency at the anterior pituitary. In summary, central hypothyroidism is all about problem at the upstairs, affecting the connection between the hypothalamus and the anterior pituitary. So if hypothalamus is in trouble and it's not releasing enough of thyrotropin releasing hormone, there'll be no message sent to the anterior pituitary that is responsible for releasing thyroid-stimulating hormone that should act on the thyroid gland for thyroid hormone synthesis, thereby leading to hypothyroidism. It could be as a result of hormone resistance. There's a possibility of generalized thyroid hormone resistance. So if that is the case, the effect of the hormone will not manifest clinically, and then it will be, features of hypothyroidism. Hashimoto thyroiditis, like I've said in my first presentation, we cannot complete the story around hypothyroidism without reference to Hashimoto thyroiditis. It is an autoimmune condition and it has so many different names, up to 4 or 5 of them. Check my first presentation. I can remember them right now, but I want you to check, okay? It could be called chronic autoimmune thyroiditis, and I have published everything that you need to know about Hashimoto's thyroiditis. Check my channel for that. Also, drugs and medications. Lithium. I have published a separate presentation on effects of lithium on thyroid gland. How exactly lithium could be responsible for hypothyroidism? Check my channel for that. Amiodarone. I made a separate presentation on amiodarone as well. There you will also find how amiodarone could affect the thyroid gland. Please check my channel for that also. Also, we have Ethionamides. That is propyethyl, uracil, or the group, all of them in that group, methimazole and co. Why do we need them? We need them because we need to suppress, the symptoms of thyrotoxicosis or Graves' disease or hyperthyroidism or thyroid storm. When we're doing that, we're bringing down the level of thyroid hormones, and it might be excessive, treating the individual to hypothyroidism. All other medications that could be implicated in hypothyroidism will be interferon alfa, interleukin-2, Tyrosine Kinase inhibitors, checkpoint inhibitors immunotherapy like temiplimab, that is Lithium, pembrolizumab, and nivolumab. Please check my channel for some of these medications. Iatrogenic. You see, in life, you are trying to help, but sometimes while doing that, you might cause some inadvertent problems as well. So, medical treatment can lead to hypothyroidism, and this will include thyroidectomy. You've taken off the thyroid for any reason that will lead to that, or there's radiation to the anterior neck or head and neck radiation, or radioiodine therapy for hyperthyroidism, Graves' disease, and so on. And of course, Graves' disease or hyperthyroidism treatment. All these are meant to do something good, right? To bring down the level of the thyroid hormones, right? But it could be excessive and tip the individual to hypothyroidism. Iodine deficiency or excessive iodine could lead to hypothyroidism. In other words, you can ask me the question then, what's the problem? You're talking of deficiency, you're talking of excess. Everything in life needs moderation, right? So just the optimum level of iodine is fine. Not too much, not too low. Congenital hypothyroidism. This might be a case of thyroid dysgenesis or agenesis or defect in hormone synthesis. In the case of thyroid agenesis, it means thyroid gland has failed to develop during embryogenesis. So we're not even finding it. And the problem is during embryogenesis. In the case of dysgenesis, the thyroid gland might be missing or located in an ectopic area, or it is formed but grossly underdeveloped. Okay? And of course, defects in hormone synthesis. All these could be responsible for congenital hypothyroidism. Withdrawal of thyroid hormone. This might be iatrogenic. Maybe the doctor stopped the prescription suddenly, or most of the times the patient is not taking the medication. So, like someone on levothyroxine to help boost the level of thyroid hormone, but suddenly stops taking the medication, or maybe because couldn't afford it, couldn't buy it, or for whatsoever, maybe dementia has set in, could not remember the time to take it, and so on and so forth. Then there will be hypothyroidism. Transient hypothyroidism. I like this definition because it means it's not going to be there for a long period of time. So the hypothyroidism will occur, but in the next few days, weeks, or months, the individual will be out of it. Then we can have that if there's thyroiditis, granulomatous thyroiditis, postpartum thyroiditis, subtotal thyroidectomy, or Graves treatment with radioiodine therapy. How do you make diagnosis? First thing first, proper and thorough history. History of thyroid diseases, history of medications that the individual is taking right now, autoimmune disease history. Because if you have listened to my previous presentations, I've emphasized the importance of reading out other autoimmune diseases, particularly when you are dealing with autoimmune thyroiditis, that is Hashimoto's, right? Surgical history that might give clue whether we are dealing with thyroidectomy here or not. Pregnancy and menstrual history, because some pregnant women will come down with hypothyroidism, and the menstrual history will give us clue whether this person is dealing with symptoms and signs of hypothyroidism already. On physical examination, we check the hair, the face, the tongue. What I'm looking for, of course, features of hypothyroidism. I'll not waste your time going through all this one by one right now because I have made a separate presentation on clinical signs and symptoms of hypothyroidism. Just check my channel for that, and that is already part 2 of 7 of this series. So sparse head, puffy face, enlarged tongue, what's happening to the hand, how about cardiovascular system, the neuro, is this person getting weight now? Any features of thyroid gland enlargement like goiter? How about lymph nodes in the head and neck region? All this will be checked. Okay, we will not limit ourselves to that. We'll move ahead to the lab. When we get to lab, the first thing we want to do when it comes to thyroid-related problem is thyroid function test. So we want to know what is happening to Thyrotropin releasing hormone that should act on anterior pituitary and give us thyroid stimulating hormone. That should act on the thyroid gland to give us T4, T3, or recombinant T3. And of course, we'll assay for the level of thyroid antibodies. Thyroid antibodies will give us clue if we are dealing with any autoimmune condition here, like Hashimoto Thyroiditis. Okay, we got our thyroid function test result back. Thyroid stimulating hormone is normal or decreasing, and T4 is decreasing. Okay, that is pointing to central hypothyroidism. Okay, in tertiary hypothyroidism, we'll be dealing with problem at the level of the hypothalamus, and in that case, TRH level is our concern. So, what is happening to Thyrotropin releasing hormone? At the secondary level, secondary hypothyroidism, the problem is with the pituitary. This time around, anterior pituitary gland. And we want to know what is happening to thyroid stimulating hormone. Because what is happening at the anterior pituitary with the level of thyroid stimulating hormone will influence the thyroid gland, giving us primary hypothyroidism. That is, the problem is within the thyroid gland itself. And that will give us the true picture when we see the value of T4, T3, or recombinant T3. And of course, thyroid peroxidase antibodies will be assayed to know if we are dealing with autoimmune condition or not. So in central hypothyroidism, that is going to be tertiary because we'll be dealing with problem at the level of the hypothalamus, affecting Thyrotropin releasing hormone. Any problem at that level will affect everything now. In the case of primary, the problem is within the thyroid gland. Remember, there is hypothalamic, pituitary, thyroid axis. And when it has reached the thyroid gland itself, we want to know what the level of thyroid stimulating hormone is, which means the impulse from the anterior pituitary reaching the thyroid gland. So, in primary hypothyroidism, we will expect thyroid stimulating hormone to be high. Okay, TSH will be high and T4 will be low. In subclinical hypothyroidism, we can have TSH that is high or increasing, but T4 is normal. Okay, we are done with thyroid function test, right? But we're not done with our investigations. We'll move on to have complete blood count done, and someone will ask me why that. How about megaloblastic anemia pointing to pernicious anemia or anemia secondary to iron deficiency from massive bleeding or hypocoagulable state? Okay, we need to know the blood sugar, the liver function tests, the renal function test because of high level of uricemia, and of course lipid profile because of possibility of hyperlipidemia. Urine microscopy, cultural sensitivity, antinuclear antibody, erythrocyte segmentation rate, C-reactive protein, and of course von Willebrand factor in case of acquired von Willebrand disease. Someone is asking me why all this? Well, we might be dealing with autoimmune condition, and there's that possibility of acquired von Willebrand disease. Radiologically, we can have X-ray done, have neck CT or CT of the head, depending on your findings and what else you still want to find out. You can have EKG done, and of course, ultrasound of anterior neck will be appropriate. Okay, differential diagnosis. Primary hypothyroidism. You know, primary hypothyroidism, we have low TSH. But remember, central hypothyroidism, we also have low TSH. Increased chorionic gonadotrophy, that is early pregnancy or molar pregnancy or cholangiocarcinoma. Of course, central hypothyroidism. Still part of differential diagnosis could be that this patient is on certain drugs, dopamine antagonist, sodium hypodate, and amiodarone. Could be that there is thyroid stimulating hormone producing pituitary adenoma, because we expect TSH to be high, right, in the face of hypothyroidism. So if there is TSH producing pituitary adenoma, TSH will be on the roof. Adrenal insufficiency, heterophilic antibody interference, generalized thyroid hormone resistance. Other differential diagnoses could be Cushing syndrome, anemia, kidney disease, liver disease, depression, pregnancy, diabetes mellitus, pyelonephritis, diet, sedentary lifestyle. We are getting all these possible differential diagnoses based on clinical signs and symptoms of hypothyroidism. So when you have all those clinical signs and symptoms of hypothyroidism based on my presentation in part 2 of this series, you'll be able to think along this line that if it's not hypothyroidism, then what is it? For example, sedentary lifestyle could lead to increased weight, and hypothyroidism will give increased weight. So that's a lot. Or somebody is having psychiatric disorder with depression. And of course, hypothyroidism could lead to depression. So, like anemia, right? Megaloblastic anemia from pernicious anemia might not be hypothyroidism, but it could be as a result of hypothyroidism. Okay? So that's why we have these large number of differential diagnoses. And with that, I've come to the end of this presentation. The next presentation will be about the treatment of hypothyroidism, and that will form part 4 or 7. Thanks for listening. Please remember to share and subscribe. I appreciate it.